I am Valentin Fuster from New York, although I have to correct somehow. I was born here in Barcelona, but I live in New York, and it's a pleasure to be part of this European Society of Cardiology meeting in Barcelona, a very, very successful meeting, a meeting that many trials were presented, actually 34 trials, and we are going to discuss at least 7 of them, which I thought were quite interesting. But most importantly, we have experts in the fields here, and I was very pleased that top people in different fields accepted to be part of this session. And let me start from you. He is Dr. Stefan Windecker. Actually, he was the co-chair of the scientific sessions, so I cannot say the scientific sessions didn't go well, just by definition. But it actually was very impressive, I have to say.
Thank you.
Stefan is chairman of the Department of Cardiology at Bern University Hospital in Switzerland, and he's a deputy editor of the Journal American College of Cardiology Interventions. Thanks very much for being here today. And here we have Dr. Bonnie Key. She's the Founders Associate Professor of Cardiology Oncology at the University of Pennsylvania, and she actually is the editor-in-chief of the Journal of the American College of Cardiology Oncology, a new journal, and actually very successful. Thank you very much, Bonnie, for being here today.
Thank you.
And then in my left, we have Dr. Jonathan Piscini, who is Associate Professor of Medicine at Duke University Medical Center, and he's the Director of Cardiac Electrophysiology there. And we don't have a lot of electrophysiology, but people die, and they say it's an electrical problem, so we have a lot to say there too. And finally, very, very pleased to have Dr. Michael Borger with us, who is the Director of Cardiac Surgery at the Leipzig Heart Center in Leipzig, Germany. So wonderful to be with you here today and to be able to share thoughts and having good discussions about, let's begin with 7 trials that I thought were interesting. And I will say that we will do it in the following way. 2 of the trials we will begin about antithrombotic therapy. Then we have 3 studies on heart failure, and then we have 2 in prevention. So let's start with antithrombotic therapy. And the first study that we are going to address is the study called PANTHER. It's a P2Y12 inhibitor versus aspirin monotherapy in patients with coronary artery disease. The leading investigator is Professor Marco Valgimigli from the Deputy Chief of Cardiology, the Cardio Center Ticino Institute in Lugano, Switzerland. So this is a very interesting study. In the design is very simple. We know patients with chronic coronary artery disease, the standard therapy in antithrombotic therapy is actually aspirin. But what about if we consider a P2Y12 receptor blocker, maybe a possibility as a monotherapy? And what about patients who underwent PCI after 1 year? We are facing a patient with chronic disease, and again, we have the issue of monotherapy. So this is actually what this study was designed for. This is comparing monotherapy with a P2Y12 inhibitor, was clopidogrel, pasugrel, or ticagrelor, or aspirin, and we call for secondary prevention, either it's chronic coronary artery disease or patients following dual antiplatelet therapy following PCI. Well, here what they did is they got into actually 5 trials, and they look at, 7 trials, and they pulled them all together: the ACCET, the CADET, the CAPRI, the DACAP, GLACI, and host exam and TCAP trials. And they were about 35,000 individuals participating from 492 sites across Asia, Europe, in North America. The study population consisted in 24,000 patients, and they were assigned, approximately half of them, to a P2Y12 inhibitor. Mostly was clopidogrel and ticagrelor. In the other half, aspirin monotherapy. And the follow-up was about 1.5 to 2 years. Well, the question is, what were the outcomes, or the primary efficacy outcomes? Was actually cardiovascular death, myocardial infarction, and a stroke. And then they had another, was mesha bleeding as an outcome, as a secondary outcome, or the combination of mesha bleeding and the three aspects that I mentioned for the primary efficacy deadline, or excuse me, endpoint. Well, here, let me go into the results. The primary efficacy outcome, cardiovascular death, myocardial infarction, and stroke, in fact, was in favor of the P2Y12 inhibitor, 5.5% events versus 6.3%. The driving force was the prevention of myocardial infarction. Then they went into bleeding, very similar between both groups, except a little bit better with the P2Y12, less GI bleeding, less hemorrhagic stroke bleeding. And then the pulling all together, everything, actually the results were again in favor of the P2Y12 inhibitors, 6.4% versus 7.2%. So I'd like to read the conclusions, and then we will have an interesting discussion here. The conclusions were presented as follows. P2Y12 inhibitor monotherapy was associated with lower risk of cardiovascular death, myocardial infarction, and stroke compared with aspirin monotherapy in patients with coronary artery disease, mainly owing to a lower risk of myocardial infarction. Second, the incidence of mesha bleeding was similar, but gastrointestinal bleeding and hemorrhagic stroke were lower with the P2Y12 inhibitor monotherapy. And then finally, based on available randomized evidence, long-term P2Y12 inhibitor monotherapy may be warranted instead of long-term aspirin monotherapy for secondary prevention in patients with coronary artery disease. These are the 2 points on the discussion that I would like to have your opinion. How significant, with huge number of patients, is to move from 5.5 events to 6.3 events? This is what it's all about. This is number one. And the second question we will address actually will be about the cost, aspirin versus P2Y12 inhibitor. So Stefan, tell me about the impact of this. I gave you the statistics, the results was positive. We are talking about thousands of patients. How do you react to it?
Well, first of all, the beauty of this study is that it really represents anybody with coronary artery disease. It included patients that underwent coronary artery bypass surgery. The vast majority have had prior PCI, but there was also a considerable portion of patients that were treated just medically for coronary artery disease. So really, this study encapsulates the entire spectrum of patients with coronary artery disease. I think the significance is 2/3 actually received clopidogrel. And the other 1/3 had a more potent P2Y12 inhibitor, predominantly ticagrelor in that study. And coming back to your question regarding the cost, clopidogrel being generic, it certainly makes it a very attractive option, being more potent in terms of efficacy, but at the same time having a similar safety profile in terms of bleeding, even better in terms of GI bleeding and intracranial hemorrhage. So overall, I think this will be practice changing in the long run.
Okay, Bonnie, are you so positive?
Yeah, I think it is a very important study, and I think the evidence has been turning that aspirin is falling out of favor overall. I think one population, though, that wasn't examined and that has typically been excluded from cardiovascular trials is the cancer population. We know they are increased risk of bleeding and thrombosis.
Yeah.
So I'd like to see such a study in the cancer population as well.
Okay, what do you think, Michael? Here's a surgeon.
Tell
us, what do you think?
It was also a very important study for me as a cardiac surgeon, notably because of the confirmation that P2Y12 inhibitors are not such potent stimulators of bleeding, because this is a situation that we face very often in cardiac surgery, and in the past we used to say, oh, you had to stop clopidogrel before patients undergo coronary bypass surgery. We're now more and more comfortable on operating on patients on clopidogrel, and after seeing this study, I will say, we should probably never stop clopidogrel before coronary bypass, just like we don't stop aspirin. Ticagrelor, we're a little more cautious there. And then post-bypass surgery, as you know, aspirin is one of the mainstays in order to prevent future infarcts and graft thrombosis. And maybe clopidogrel would be just as effective or with a better safety profile. We'll have to see. That data will be interesting.
Jonathan, what do you think?
I am surprised that there was less bleeding with the P2Y12 inhibitor. As a heart rhythm physician, though, I do wonder how these results will be implemented in practice. And in my practice, there are so many patients with atrial fibrillation who have an oral anticoagulant and chronic coronary artery disease, and they get treated with chronic antiplatelet therapy in addition to an oral anticoagulant. And I guess as I was hearing these results, Dr. Fuster, I was wondering, well, now how many patients are going to end up on a direct-acting oral anticoagulant and a P2Y12 inhibitor? And so that's one thing that I think we'll need to watch out for, because clearly this is restricted to patients with chronic coronary artery disease.
Yeah, I have 2 points of caution. And again, what is nice about these discussions, all of us have points of view. I did the study on aspirin and saphenous vein grafts, actually the original study. And there's a study now, a large study comparing with clopidogrel. And the results are not favoring the clopidogrel or the combination. So what I'm saying, in following bypass surgery, I would still be cautious in trying to use clopidogrel, because all the data is really with aspirin, with a long follow-up. But I still go back to my question, Stephen. I have problems with a relative change of 1%. As I say, as a huge impact of change of medications in the future. If you tell me, well, the bleeding is less, which is interesting, with the P2Y12, I say, well, maybe it's worth it, but I have some questions about the statistics here, and I just would go back to you again.
So the absolute difference of 1% is translating into a relative risk difference in the order of 12%. This is not huge, but on the other hand, it's against the background of other therapies. And and I think at the end of the patient perspective, you want to take the more effective, equally safe drug. And I think there it's also important the adverse effect profile. And if you have a lower bleeding risk and no other disadvantages, I think that's advantageous. I think an important point Jonathan made, we should not combine antiplatelet and anticoagulant in patients with atrial fibrillation. I think that's a very important take-home message.
Well, anyway, so the overall view is that it's an interesting trial. I think we talked to clopidogrel, which is not high cost, and in a way maybe less bleeding. So it's a turn towards the future, which I think is quite interesting overall. Well, thank you. Now we have a second paper, which is quite fascinating actually, and we are going to be talking about rheumatic heart disease. The story here is that the NOACs came very rapidly into the whole cardiovascular field. And one of the first studies were the use of NOACs in patients with prosthetic valves, and it was a disaster. Then studies began to evolve atrial fibrillation with other native cardiovascular diseases and appeared to be working better. And actually, I have to say there is a Korean study. It was published in 2017. Actually, I had the chance to review it. 2019 was a retrospective study saying patients with mitral stenosis and atrial fibrillation, this was always a question mark, actually not do the same or even better than vitamin K antagonists. This was a retrospective, if I recall, was a retrospective study. Well, here we have a prospective study that I'd like to present. And so the study is called INVICTUS and was presented by Dr. Connolly from Hamilton, Ontario, and is entitled Rivaroxaban in Rheumatic Heart Disease Associated Atrial Fibrillation. It's published at the same time by the New England Journal of Medicine. And the background is there are no prospective studies of patients with atrial fibrillation in valvular heart disease due to rheumatic fever, except the one retrospective I mentioned. So these were the specifics. They enrolled patients with atrial fibrillation and echocardiographically documented rheumatic heart disease. I have to say that more than 80% of the patients were significant mitral stenosis, and about 22% was significant mitral regurgitation. So it's very much focused on the mitral valve and particularly mitral stenosis. And they had one of the following characteristics. CHA2DS2-VASc should be at least 2. The mitral valve area no more than 2 square centimeters, and atrial spontaneous echo contrast could be there, and so forth. And the patients were randomized into rivaroxaban and vitamin K antagonists. I think the rivaroxaban was 20 milligrams or 15 milligrams according to renal function. And then the INR with adjusted vitamin K, I think, was between about 2 and 3. Okay, this was basically the basis of the study. The primary efficacy outcome was a composite of a stroke, systemic embolism, myocardial infarction, or death from vascular causes. And the primary safety outcome was actually mesh bleeding. Well, this was the study. How many patients? If I recall, this was an international study actually, and it's about 4,500 patients were included. The average age, 50 years, 72% were women, and this was an intention to treat analysis. And we are going to get into statistics again. This is interesting. It's about 4 years of follow-up. And they look at all the events I mentioned, what difference in days when the first event happened in the rivaroxaban versus the group treated with vitamin K antagonist, 100 days. So let's be sure we keep this in mind. So the first event on rivaroxaban was 100 days earlier than the first event in vitamin K antagonist. And then they look at actually mortality. Interesting. Incidence of death. How many days was the difference? 70 days. So, in conclusion, among patients with rheumatic heart disease associated atrial fibrillation, vitamin K antagonist therapy led to a lower rate of composite of cardiovascular events or death than rivaroxaban therapy. Jonathan, again, I have a little bit of a problem here. First, because I remember reviewing the Korean study, it was very, very little difference between vitamin K antagonist and rivaroxaban. Do you think this difference is huge? Remember, 100 days difference in a 4, 5, 6 year follow-up with rivaroxaban in favor and mortality 7 days in favor. Would you say that this is very clear we should give vitamin K antagonists in patients with atrial fibrillation and mitral valve disease?
I do. I think rheumatic heart disease and mitral valve stenosis are unique situations. And we've known that for a long time. We know that these are high-risk patients, and vitamin K antagonism has worked well. And the events that were different between the two arms, these were not minor events. These were major cardiovascular events. And the lack of proportional hazards does make interpretation a little bit challenging. But I think one of the really important things is the time and therapeutic range. Before the trial, and the subjects was 30%, and as the trial went on and they got on therapy, they got the time and therapeutic range up in a very good range at the end of the study in the, I think, high 60s. So I think one of the main takeaways is that yes, vitamin K antagonism can be very helpful for these patients and is preferred over direct-acting oral anticoagulants, but you really got to keep the TTR high.
Bonnie, in the discussion, they say the data was very close and could be related to chance. I'm just saying this because we can become very excited, but when you look at the statistical analysis of this, you know, I think what you said is correct. Maybe 100 days of difference, but the events we are talking are very important. So this is true. Tell us what you think.
I'll tell you, I was surprised by the findings, and I think you're right. The devil is always in the details. I think more data, we need more data to understand this. And the question is why? Why did this observation occur? What is the mechanistic basis? What is the clinical basis? Was it that patients who were on vitamin K antagonists, they had more touches with clinical providers and had somehow better care? I think it's still a question out there. But I agree, it is a special population, and they are different at increased risk.
Stephen?
I find the study fascinating, and in a sense also good news that an old cheap drug can be applied in these lower income countries where the study was performed. But I remain puzzled because the original question they asked, that is thromboembolic and stroke risk reduction, they adapted the primary endpoint because
Exactly.
they didn't have enough events. And actually, Jonathan, I agree with you. Usually you think rheumatic heart disease, they have a high risk for thromboembolic events, but they did not have many events. So what they included was death of vascular causes and unexplained death. And there, again, the unexpected finding for me, for patients with a mean age of 50, they had a very high mortality. So obviously that may be related to the environment they live in and other factors. But I think the drugs in themselves, they didn't address so much the thromboembolic risk than perhaps something else. And I found it interesting in the discussion that they said, well, maybe the higher attention by physician visits due to INR control may have contributed to the difference in mortality.
Well, it's a reality, and actually I have to say, and I'm sure, Michael, you will be in agreement, rheumatic heart disease still predominates in low-income countries, and the use of vitamin K is not so simple, you know, inhibitors for the INR. On the other hand, the NOACs are expensive. So still we have that issue, but you have a final comment about this type of trial?
Yeah, as a surgeon, obviously we don't see most of these patients at this stage of their disease process. It's basically when they are presenting for surgery. My only comment would be what you had already alluded to, that the NOAC trials in heart valve surgery patients were a disaster, but there was the PROACT trial, which was a very specific mechanical valve where it was not a disaster, and with a lower dosing of Coumadin, they were able to show that this valve performed well. And now there is the PROACT 10A, which is looking at DOAC versus Coumadin, and those results will hopefully be out in the next 1 or 2 years.
Thank you. So it's an interesting study, but raises some questions about the endpoints, which are beyond thromboembolic endpoints. It makes things a little bit more difficult. Well, these are the 2 antithrombotic trials. Now we get into a hot subject, which is heart failure. And let me see how I would like to start with maybe if you have a controversy between you, Stefan, and you, Michael, because we have a surgeon here and we have an interventionalist. Here we are talking about a very interesting subject that we know very little, frankly. These are patients with significant coronary artery disease and left ventricular dysfunction. And actually I was reviewing yesterday this for another talk, and it's interesting when you go to the literature, some data in the STITCH trial, you know, that bypass surgery could be interesting actually versus medical therapy. This was the STITCH trial, and now the ischemia trial also has something in favor of bypass surgery in patients who really have extensive coronary artery disease and left ventricular dysfunction. But what about the guidelines? The guidelines today about a patient with multi-vessel disease and left ventricular dysfunction actually, the European Society of Cardiology says if the patient you feel is not at a very high risk, the patient could be considered for bypass. And PCI is secondly very far in the road. And by the American College of Cardiology, American Heart Association, they don't talk about PCI at all. And they say revascularization as a class 2, in this case, the European is class 1, could be considered. So there's nothing clear at the present time. So here we go into the REVIVE study. This study, percutaneous revascularization for ischemic left ventricular dysfunction is the title, was presented by Professor Divaka Pereira from King's College in London. And let's go into the study in itself. The hypothesis is that revascularization with PCI improves event-free survival in patients with severe ischemic left ventricular systolic dysfunction compared with optimal medical therapy. All right, this is the hypothesis. And let's now go into the details. What were the inclusion criteria? Extensive coronary disease, I already mentioned. Left ventricular ejection fraction less than 35%. And then, interestingly, more than four myocardial segments that could be revascularized by PCI. This is part of the inclusion criteria. And then what we have here is the patients who entered into the study. Actually, there were 700 patients from the United Kingdom from 2013 to 2019, and then the patients were following to 2022. And the patients were randomized, as I described, with PCI versus optimal medical therapy. Primary outcome, all-cause death or hospitalization for heart failure. Now, secondary outcomes, ejection fraction improve, ejection fraction is quality of life better, and then unplanned revascularization and NT-proBNP levels were also part of the study. Well, let's go into the results. Primary endpoint, all-cause mortality and hospitalization for heart failure, no difference. The components of the primary outcome, I mentioned, no difference either. The left ventricular ejection fraction, no difference. The quality of life, no difference. Medical therapy versus PCI. NT-proBNP, no difference. And here is the conclusions. Patients with ischemic cardiomyopathy continue to have high rates of mortality and hospitalization for heart failure, even with contemporary medical and device therapy. Percutaneous coronary intervention did not reduce the composite incidence of all-cause death or hospitalization for heart failure at a median follow-up of 3.4 years. Percutaneous coronary intervention did not incrementally improve left ventricular ejection fraction or provided a sustained difference in quality of life. And here I am puzzled for one reason, Stephen. When they go to a secondary outcome, which is unplanned revascularization, it was significantly higher in the group that was medical therapy. And this leads us to a discussion that I think is very important. You can look at very hard endpoints, but patients cross over here, very significant crossover from the group optimal medical therapy to PCI. So here we have a negative result, but something that is a little bit of a puzzle. I'd like to know your opinion as an interventionalist.
Yes, so I think in strategy trials where we compare revascularization versus medical treatment, initial medical treatment strategy, it's very important to look at those additional outcomes. So in other words, if you have the ability to cross over at any point in time, then the risk differential between any kind of therapy becomes smaller. So I think this is an important consideration, and the endpoint is important because it is unplanned revascularization. I think another point, nevertheless, I would like to raise is, and the question is, how representative is this study for everyday clinical practice? So the trial recruitment was over 6 years in a multi-center trial across the UK. That's a very long period. The second is usually these patients have an indication for coronary artery bypass surgery. So how were patients selected to be included in the trial rather going to coronary artery bypass surgery? And the reason I'm asking that question is we need to better understand the phenotype of this patient population. Was it truly ischemic cardiomyopathy? Or was it in cardiomyopathy with bystander coronary artery disease? Because if you look at the characteristics, 50% of patients had 2-vessel disease, whereas only the other 50% had 3-vessel and left main disease. So I really think we need to better understand how patients were selected for the trial rather than, let's say, a surgical revascularization, and what was the true contribution of coronary artery disease to the cardiomyopathy.
Are you raising the question that perhaps there is a role for angioplasty? The results are negative, the way I presented, but in the way you are talking about.
I definitely think, obviously the trial disapproves this, and I also want to upfront say, obviously, the heart failure medications today are so powerful.
Yeah.
We really need to acknowledge this. On the other hand, you know, if you look at other endpoints, first they look at all-cause mortality, no difference. But if you look at cardiovascular mortality, the hazard ratio is 0.88. And if you look at myocardial infarction, and you look at all of them, including periprocedural MI, unsurprisingly, there's no difference. But if you subtract periprocedural MI, and that brings us in another controversial definition of MI, then numerically, actually the PCI group did better.
Thank you. What do you think, Michael?
Well, you asked about possible conflict between Stefan and I, and we always agree with each other, so I'd just like to start with that. But I would say that this study underscores what's in the guidelines, is that PCI plays a relatively minor role in these patients. Surgery in the STITCH trial did show a statistically significant benefit for mortality, but it took a while to demonstrate that. Maybe 3.8 years is not long enough yet for PCI. But one important point I would like to point out is that there were on the median number of vessels treated was 2, and the median number of bypasses done in stitches was 3. So although these are higher risk patients, as long as we don't feel that their overall clinical profile is prohibitively high risk, I still think they belong in the domain of surgery because we can more effectively bypass many regions and protect against possible future de novo stenoses.
Thank you. Bonnie, what do you think?
Yeah, I think there are a number of key considerations about this trial that we need to better understand in order to apply to our patients. I completely agree that we need to understand more about the functional versus anatomical correlations.
Yeah.
Who does this actually apply
the
to?
Yeah.
What was also curious, though, I thought, and it'd be interesting to get folks' perspective on the initial improvement in symptoms that was observed early in the intervention group in terms of, I know over time, it was no longer statistically significantly different, but early on, they did have an improvement in terms of their symptoms.
It's interesting, we saw this in the FREEDOM trial. In our interpretation of the symptomatology, for example, bypass surgery was superior to PCI, but interestingly, angina comes after a year, and we saw a lot of microvascular disease. What I'm really saying is that these patients with significant and extensive disease is not simple, not as simple as we are dealing with the epicardial arteries, in our interpretation at least.
And there could be a placebo effect as well. The NT-proBNP were not different.
Yeah,
they were not different at all.
Yeah, sure. Yeah. Jonathan, last word.
Yeah, I mean, anytime you see significant crossover, you get worried that you're not having an even-Steven comparison between the two arms, and that the research question you think you're answering, you're not. I would say that's one thing. The other thing that I think is really striking from this trial that we should probably apply to all of cardiovascular medicine is, as our therapies advance, we continually need to reassess therapies. And there are ongoing trials of, for example, the implantable cardiac defibrillator, given the advent in medical therapy. So I think trials like this are very, very important.
Yeah. Okay, thank you very much. At least we can say bypass surgery is the way to think, at least possibility. PCI cannot be neglected. Let's put it in this way. Is this okay, Michael?
Good, good.
All right. You accept some,
Yes.
he would like to. make it a little bit more. But anyway, thank you very much. Now I think this is a very good, the study presented in the Lancet about SGLT2s, I think is one of the best studies I have seen in terms of these drugs in heart failure. And I like to present this with some detail because it has to really be understood. And I have to go historically, I'm sorry, but I think it's necessary to understand the results. As you know, these SGLT2 inhibitors have been very successful for the heart and for the kidney in a number of conditions, in heart failure, patients with or without heart failure, and otherwise it looks like these SGLT2 appear to be like miracles. Then after all of that, it began to be used for patients with ejection fractions that were intermediate, and the question is, or ejection fractions that were close to 40% or better, and we have here the Emperor preserver study with empagliflozin and the other one with the liver, dapagliflozin, and then these studies actually in the last 2 years have raised the possibility that these drugs can be very helpful in heart failure, but in this case with preserved ejection fraction. So what they did in this paper, they put together to gain power these two trials, the liver trial and the Emperor trial. And then once they did this, they went even further. They added three other trials. The two in heart failure, DAPA-HF and Emperor reduced, and then one that is heart failure of any kind of ejection fraction, the soloist WHF trial. So what they really tried to do is step by step to see what is the role of these drugs in patients with different ejection fractions. This was really the question, and they did this in a way that I think is very, very nice. Well, let's see what happened here. First of all, when they compare both empagliflozin and dapagliflozin on the Emperor preserve and the liver trials, these were actually 12,000 participants when you put together these two trials, and they look at composite of cardiovascular death or first hospitalization for heart failure. And the results were very consistent. Not only both aspects together were significant in favor of these two trials, these were ejection fractions of 40% up, but also independently, cardiovascular death and first hospitalization independently, they were significant when they put both trials together. Then they added the trials on heart failure, which we knew were positive, and here the results were even more significant, and here they added an all-cause of mortality. So the concept is SGLT2 inhibitors reduce the risk of cardiovascular death and hospitalization for heart failure in a broad range of patients with heart failure, supporting their role as a foundational therapy for heart failure irrespective of ejection fraction or care. So this is actually the results of this altogether, of the use of these two different drugs. There are many questions that I would like to actually ask you. First of all, when you look at the results, you realize that the data decreases a little bit of power as the ejection fraction goes up, but it still is significant with ejection fractions that are actually close to normal. And one question that worries me, and I like to have your opinion, is there are now 4 different drugs, or even more, for heart failure, and how do we deal with them? So this is difficult, and maybe, Bonnie, I'd like to ask you, first of all, what is the view of the paper? I think it's very well done, frankly. And second, how do you handle your heart failure patient? You have there ACE inhibitors, you have all these type of drugs behind this, so tell us what you feel.
Yeah, I agree that the trials and the meta-analyses all very rigorously executed, and they are very important trials. I think you raised critical questions about where and when, and the pillars of heart failure therapy should we be starting these drugs? Because heart failure patients get overwhelmed with the number of medications and the costs and adherence. And these are critical points that need to be addressed in terms of when and how should SGLT2 inhibitors be implemented. The other key things with all these studies is blacks and other minority populations were very low in terms of the patients enrolled. And we need trials in other populations as well to understand the role of SGLT2 inhibitors, particularly in blacks and African Americans and minority populations. And then I think the other big question for us is mechanisms. Why and how do these work?
Yeah. Michael, pulling all of this together, if I have a patient that comes to me with an ejection fraction of 40%, and you say, well, let's begin all these therapies, and you have a lot of therapies, but it seems to me, though, the advantage of SGLT2s is you can have renal disease, you can have any disease you want, cardiac disease and so forth. They just work. It's not like a possibility of a first drug to be used. I'm just asking you.
Well, I think the beauty for the clinician is it's a single dose. You don't need to do any dose adjustments, and you have minimal impact on blood pressure. So you really can give this drug more easily than anything else. Beta blockers, you need to titrate. Sacubitril valsartan, you need to titrate. MRA inhibitors, you need to look for the renal potassium and so on. So the beauty is it's very simple. You can give it a single drug. The other thing, you know, from a pathophysiological point of view, I was always puzzled. Why do you have that cutoff binary of 40%?
Yeah, that's another issue.
Yes.
Yeah. Thank you. Jonathan, what do you think?
It's incredibly convincing. I think, a lot's been made of the comment foundational therapy. I think that's right. I'm not so convinced that it decreases atrial fibrillation. The studies have been mixed. Yeah. So while we have an answer for heart failure, I don't know that we have an answer for atrial arrhythmias just yet.
Well, to me, this is a polypill. If you look at the polypill, the definition is you work in different mechanisms. That's what the polypill is about. So that to me is a pill. Is it not correct? It's a pill that works on so many, and you said so many, we don't know what, but it does. To me, to start with that drug is appealing, it's simple, it's one dose, it's fixed dose. Are you excited?
I would have to say it's nice of you to ask me a question, Valentin, but I have to say it's not my area of expertise. And it is, though, for me, who looking after patients at the surgical stage, also sometimes confusing, trying to figure out why the clinician started which medication at which time and what the decision-making process is. It's hard to get a good understanding of that from somebody who's a non-heart failure specialist.
Yeah, thank you very much. Certainly, I think this paper is a great paper. The way it was done is beautiful. Well, thank you very much. And we have a final paper in heart failure, which is, for me, it's difficult to understand from the point of view of methodology. And let me go, this is the DELIVER study, but it's the DELIVER study rather than starting the patient at any time and you follow. You start patients by age, and then you move on. Different ages, see what the results are. Let me go over in some detail. First of all, perhaps to be repetitive, we are still talking about patients with reasonably good ejection fraction. And these patients actually have been followed in the two trials we mentioned before, the IMPEROR trial, the DELIVER trial. They have been followed for 2.5 years. And now they come with the story that without data, you can follow this patient for 12 years. This is statistical approach, which is you go to previous study and you begin to mimic what happened with other studies. And they pick up two studies. One was in ACE inhibitor published in 2003, patients with left ventricular dysfunction. And the others in the recent study was sacubitril valsartan. And they are able to project curves according to what happened in the first 2.5 years. And again, don't ask me for the details, it's just to me, it's a little puzzle. And as reviewer of JACC, I am beginning to see more and more papers that without data, they are still now to project long-term data. And it's a puzzle to me. And I have to really learn more about what is the methodology that is just being used. Well, this is actually what they did in this particular study. It's an endpoint of a primary endpoint cardiovascular death or worsening heart failure. These are patients with a phase 3 study, a placebo-controlled trial. Dapagliflozin was compared with placebo. Average age of the patients 40 years. These patients have a left ejection fraction more than 40%, and they started with age. And then they say, well, at given age, what do you expect this drug is going to do versus placebo? And they projected this, and then they say the estimated survival free of trouble with dapagliflozin is 9.7 years. There's no data going there. Whether with placebo is 12.1 year. And then with every age, they give you some data. In fact, it's interesting, and what they are showing is these drugs that we give now with close to normal ejection fraction. There's only 2.5 years of follow-up, but we are now beginning to talk about 10 years of follow-up without the data being there, and certainly the drug dapagliflozin appears to work. So Jonathan, do you know about this approach?
I'm familiar with these types of approaches. They, like you, Dr. Fuster, they give me a little pause. You know, especially in arrhythmias, we know that the time from diagnosis is a really important factor. And in several studies where SCUD-HAF, for example, where you go back and contact the patients after many, many years, the event trajectories are different. Sometimes you get more benefit over time, sometimes that benefit attenuates. So the assumption that the event rates are going to continue at that pace does give me pause. And I think they're interesting studies to do, but you know, we need to be cautious when we think about applying the results.
I was very involved on congenital heart disease on tetralogy of Fallot in Mayo Clinic. I studied the first 500 patients with John Kirkland. And you know, the mortality in the first 30 patients was 50%. So he had to start projecting those curves. Today, you guys would not be operating at tetralogy of Fallot.
His textbook was full of those projected curves, and in cardiac surgery.
Things change, and I don't know what you are projecting. What do you think, Michael?
Well, I think I share the concern and the caution that needs to be there in the interpretation. Yet I think one thing that is important also from a patient perspective is it's not what we usually do in clinical trials, just look at the first event. From a patient perspective, it is any event that matters. And I think, therefore, cumulative event analyses, I think they are really important to comprehend what really the drugs do beyond the first event and the primary event. So I think you need both, but I share the caution in terms of the modeling aspect of these studies.
Well, I think it's also a matter of education. I think we need to understand better the methodology. Bonnie, any final comments?
No, I completely agree that we do need to interpret these with caution. But if you look on the data on whole, I think there's tremendous benefit.
Good. Then we have two projects here on prevention. Well, I will present, and I presented in this meeting, the SECURE trial, and it's basically a trial on a polypill. And this study actually was much more difficult than what people think. And there is a history here. It's a history of 15 years. And it was about 2007 when we began to at least I was in charge of this National Heart, Lung and Blood Institute in Madrid, the CINIC, and we said we really have to get into trials. And at that time, adherence began to be a problem in our thinking. And I said, you know, we should develop a polypill for secondary prevention. There was a lot of talk about primary prevention, which I think is difficult. So then we went to a number of companies in the United States, and to make a polypill, they said, this is very interesting, but we are not interested. And the reason was because the HIV They developed polypills and were a tremendous investment to really make these polypills and then to go all over the world. So, and I was interested in global health. We can make something simple and much cheaper following myocardial infarction. So we found laboratories of a CEO and Ferrer Laboratories in Barcelona, actually, who's very socially oriented and says, you know, if we can go to global countries and have something cheap and simple, maybe we will achieve something. So we started. The problem with that, and this was the first 5 years, is to make a polypill is quite complex because the pills interfere with each other, which is different than taking the pills separately. So we had to do 50 polypills. And we finally found one with aspirin, simvastatin, and ramipril. And then we used it in a study with 5 countries, which was an adherence study. And we found that indeed, following myocardial infarction, people taking the polypill at that time, the adherence was much better than actually taking the pill separately. This was the first 5 years. The second 5 years, we did a study with Aetna, you know, a very important insurance company in the United States. They had 14,000 patients with myocardial infarction. And we look at the pharmacy, how was the adherence, and what were the events. This was retrospective, and we found there was a close relationship between adherence to medications in this study and the cardiovascular events. So those with the highest adherence did much better. This was the Aetna. But this was retrospective, and this led the last 5 years to the prospective study. There's any relationship between adherence and cardiovascular events prospectively in patients with myocardial infarction using a polypill, which this polypill, the second one was not simvastatin, was atorvastatin. But this was the study. This is a 7-country study in Europe and was funded by the Horizon 220 European study. And there were 2,500 patients recruited from 113 centers across 7 European countries. And then the study actually, the reason for the success of the study, in my view, was that we met every week or two with all the investigators from the beginning, which is, if we had not done this, motivation is very difficult to carry a study like this. But it's something I say, that are difficult studies, but the most important is how you communicate and motivate investigators. Anyway, the study is 2,500 patients. We use aspirin 100 milligrams, atorvastatin 20 or 40, depending of the tolerance. Most of them was 40 milligrams. And ramipril, 3 dosages in 3 weeks apart, because 2.5, 5, and 10. Most reach 10, but we are always worried with ACE inhibitors with side effects at the beginning. This was the reason. The primary composite endpoint was cardiovascular death, myocardial infarction, stroke, or urgent revascularization. And the key secondary endpoint was the same, except for revascularization. One issue of the study, one limitation of the study, was that COVID came in. All the patients were entered, most of them before COVID, 2/3 were. But 14% of the patients in the whole study did not have follow-up. And the main issue was actually COVID. And what we did by intention to treat is to use the last visit of these 14% patients. And this was one of the difficulties of COVID. Well, the results were certainly very interesting. Was a significant benefit with the polypill versus the usual care, which taking the pills separately. And what is interesting is the curves began to separate from the very beginning. Mm-hmm. And actually at 4 years continue to separate. So the potential of the polypill may be more than what we think. But what made us to believe that this was not by chance is that we did 16 groups that were pre-trial already. We were going to look at in the 16 groups, the polypill work on each group, even in each country, and looking at things, which gives you a little bit of a sense of validity, I would say. The secondary endpoint, without reintervention or revascularization, was even more significant, and this is the data actually. The primary outcome, 9.9% events versus the usual, on the polypill versus the other one, 12%. In terms of the secondary endpoint, 8% versus 12% events, with the polypill being the lower number. And what is interesting was cardiovascular mortality from 3% to 6% with a 33% relative decrease in risk. Cardiovascular mortality was really a driving force in all of this. And then we have all the 15 groups. And here comes the question, how this works. And we look at adherence, which is always difficult, but we use the so-called Morisky survey, which you have 8 questions to each patient. And the questions go about adherence. And then we have low adherence, it is less than 6 point, middle or high. This was very highly significant. One can question the method, but there was no question, it was very consistent between the polypill and the pills taken separately in terms of p-value 0.001. Then the question is what happens biologically, because you say, well, more adherence means LDL will drop and everything will drop. Well, what we found was, it's not surprising to us because we found this in the original focus study of adherence. You cannot measure aspirin what it does. You know, it prevents clots, but how do you know that the polypill does and the other doesn't? The ACE inhibitor is the same. The dose we give doesn't drop blood pressure significantly. So the LDL was the puzzle, was the same in both groups. And you know, one of the possibilities is the pleiotropic effect of statins. There is data following myocardial infarction. These patients were entered into the study within 2 weeks. That this drug, statins can be antithrombotic and anti-inflammatory. And I say this because the curves diverge from the beginning and gives you a sense that something is happening very early. They don't necessarily can be with the LDL kind of thing. So the conclusions of the study is the treatment strategy based on polypill-containing aspirin, atorvastatin, ramipril led to fewer recurrent cardiovascular events following myocardial infarction, presumably due to improved adherence. Use of a polypill strategy is safe. There was no difference, with no differences in adverse events between groups. And the use of a cardiovascular polypill as a substitution approach could be an integral part of a global strategy to improve secondary prevention. And I mentioned in the meeting, and I think it's quoted in the paper that came out yesterday, is that the WHO in 2003 actually wrote, the most important thing we have to do today is increase adherence. And maybe we should pay attention to that because we do so many things that are sophisticated, but the patients don't take the drugs, and I think that's the question. Well, anyway, this was the presentation. I don't know, well, any comments, Michael, about the...
Well, I completely agree with you. We have so many effective therapies, but what we are neglecting is implementation. And I think in strategy where you take a single pill rather than 3 individual ones has a tremendous impact also on patient satisfaction. And I think that's what you also investigated in SECURE. You asked patients about their well-being, and in all scores and domains, they were feeling better. Yeah. And I think what could be more convincing than a strategy that clinically is more effective, but at the same time also affects positively patient well-being. I think this is very convincing, and any patient would submit to you, I rather take one single pill than a plethora of individual pills.
It's interesting, Bonnie, you know, as we said in medicine today, we are in 2 different streams. You know, one is personalized medicine, and the other is simple medicine. And I keep saying that when we go to global health and in general, we should be simple. But when we go to specific disease entities, you know, that perhaps are more rare, we might be going into personalized medicine. So I am not against personalized medicine, but I think we have to do a lot with simplicity, though.
Yeah. It's like what you say with the JACC journal, simple but insightful. And I think congratulations to you firstly also on this tremendous trial. And I think adherence, as Stefan was saying, is key. We need to make sure patients are taking their medicines. We can design the best medicines, but they need to actually take them.
What do you think, John?
I think it's great for patients. Simplicity is fantastic, but I'll be honest, it's also great for clinicians. You know, it's so hard when the patient comes in with 10, 20, 30 medicines and you're trying to do medication reconciliation, you lose tracks of things. I really like the polypill. Gets the patients on the right medications. It's one medication to keep track of. I think it can improve practice, and again, in a myriad of ways.
It's interesting, the focus trial of adherence that we did originally in the first 5 years, we found that 50% of the problem was really physician. And that is, the physician doesn't prescribe, or is not following the patient and so forth. So what do you think?
I would think it's one of the most important studies of the Congress, actually. Adherence is an area that still needs more research and is an increasing problem the older the patients get. Not just the polypharmacy, but also the multiple prescriptions. It becomes more of a complex process, and the more we can simplify it, the better.
Well, thank you very much. There is a final paper on prevention, the so-called DANCAVAS trial, 5-year outcomes of the Danish cardiovascular screening. I have to tell you, this has a history. The Danish group, they have fantastic registry in Denmark of any disease entity that you may. And they had a study, I remember reviewing it in 2017, the VIVA study. What they did, they screened a large population for aneurysms of the aorta, hypertension, and peripheral vascular disease. And we had, I still remember in a meeting like this, we had a discussion because it was a relative improvement by doing that and then treating appropriately of 7%. And I still remember asking the question, what is the impact of this? And people say, well, we had a similar discussion then today. Well, now they came with a study that they were excited, and they increased the surveillance of the patients. So this time, what they did is 46,000 people. So this is a real study in Denmark. Is fantastic what they have. They added calcium score, with ECDBC, with CT, atrial fibrillation. Then they measure the brachial blood pressure measurements to detect peripheral arterial disease. They did this before. They look at diabetes and cholesterol blood sample. So they pull it all together, and at the very end, they found no difference on anything. These were patients between age 65 and 74 years. And what they found, maybe a tiny difference between 65 and 69 years, but not later. But I don't know what it means for the study. I have to tell you, for example, they took action in treating the patients that they found with disease, only 37%. So to know that you have a problem, and I think we have an adherence issue here too. I don't know what it is, unless you act very vigorously into what the problem is. So it's a negative result, but I'm left with the fact is how active was all of this trial, in terms of interfering with the patient and so forth. What do you think, Jonathan?
Well, I mean,
it's a negative study.
Yes.
But I'm not sure.
Screening is so controversial. It should, in theory, be easy to prove benefits, but it's so complicated and implementation's difficult. And then I think the other thing we often, in the ECG watches that have screening algorithms, make this complicated too. How much of screening gets done in day-to-day clinical practice? And so you're not really comparing screening versus not. You're comparing screening at one point in time during screening during practice. So I think it's an interesting result, probably require a lot of unpacking, but screening's just such a tough thing.
Big data, when you want to get details from big data, is very difficult. And particularly, you want to know so many things, why the study was negative. But anyway, before I ask you a question, which is, of all the studies, which one or which ones you think you are going to keep in mind that you are going to act on? I'd like to say there were 3 papers we are not going to discuss. I thought were interesting. I only want to make a comment. The first one is a paper on detection of atherothrombotic disease, atherosclerotic disease, done by the group in Edinburgh by using 18F sodium fluoride positive emission tomography. And basically what this agent does, and we have some experience with this, it looks at activity of calcium. And as the plaque grows and calcification takes place, you can detect this with this tag. It also happens in aortic stenosis. They have some publications done. And the only problem, the only question we have here is sensitivity and specificity, and that is how sensitive this is for activity of disease and how specific, and there is no answer, but I think it's an interesting fact. Then the second paper that they call the FRAME-MI trial, FFR versus angiography guided PCI in acute myocardial infarction with multivessel coronary artery disease. You know this story. Depends what patient enters into the study. You do the vulnerable plaque, or the plaque that is the culprit, you open, and then the question is, what do you do with the rest of the story, the other arteries? And here what they compare is angiography visually more than 50% with FFR, and they say FFR is superior. The problem with this study is the patients were mixed, STEMI versus non-STEMI, so it's already the start is difficult. And then the study was stopped because there were not enough patients to enter into that. So they project results, and the results are in favor of FFR, but I wouldn't go too far because of the aspects that I am mentioning, but I think it's interesting. And the third one I just wanted to, is about statins in muscle symptoms. They did actually, they look at so many patients, about 200,000 patients from 19 trials, and trying to see how statins affect the muscles. I'm a little bit worried about it, because in trials there are many things that are not published, you know. Maybe a little bit of muscle pain and you don't know and what that means. And I think it's more, here they say it's less than what is published. I would say it's probably more. What I'm saying is, in this huge data, how you can come up with succinct information. And what they say, I just read the interpretation of the data. Statin therapy causes small excess of mostly mild muscle pains. More than 90% of all reports of muscle symptoms by participants allocated to statin therapy were not due to the statin. The small risk of muscle symptoms are much lower than the known cardiovascular. My feeling was the opposite, but I may be wrong. I may be completely wrong. But this study with so big data, with so many people participating, is very, very hard to come up with succinct answers. Well, finish for what I consider, in congratulations by US co-chair of the scientific sessions. There were 34 studies, and we discussed 7 of them that I thought were interesting today, and then comment of 3 of them. But I'd like to go from you, and of all these studies, which ones do you think may trigger your interest in the future?
Well, the screening study from Denmark was also interesting in that it confirms that mass screening for aneurysmal disease is not beneficial. The sensitivity is too low. Most dissections occur at aortic diameters that are below the level for intervention, and we need better ways to identify patients that might dissect in the future. But the polypill study, I would have to say, this is the one that is going to have a huge influence on cardiovascular medicine around the world.
Thank you. Your comment, Jeff?
I thought the INVICTUS trial was really important. You know, those patients often get neglected in clinical trials, and I think it was a great trial to see, and highlights the importance of, you know, avoiding extrapolating therapies to new populations till we really have an evidence base. And then the other thing that we didn't talk today that I just think was such a huge part of the meeting is the data emerging with the factor 11 inhibitors and asundexian.
Can you give one sentence?
Yes, I mean, you know, these are drugs that theoretically could have a much lower risk of bleeding and yet still protect against thrombotic events and thromboembolic events, so it's exciting.
Comment?
Yeah, I think for me, the SECURE study, the polypill study, really is critical for our future of medicine, and also the SGLT2 inhibitor studies. It is changing the way I'll practice our medicine.
Well, Michael, you have probably the best view of anybody here.
No, I think what I found fascinating is that beside the industry sponsored trials, DELIVER and the factor 11 inhibitors perspective and so on, the other half of trials were investigator-initiated trials with major impact. So SECURE, we discussed SECURE, but also REVIVE, DANCAVAS.
Yeah.
And it really shows me that the investment of the European funding agencies, but also national efforts like in Denmark or in the UK, they are so important for clinical practice. And that was really it was something very convincing to me about this meeting.
Well, thank you very much. Here we conclude. I hope you enjoyed this discussion, and thank you all. This was a great meeting, very interesting papers that have been presented, and again, thank you very much to everybody. Thank you to the European Society of Cardiology for this opportunity, and also thank you to the American College of Cardiology, which is sponsoring this particular type of dialogue that we had. Thank you very much. Thank you.
Thank you.
Thank you.
Thank you.